So my next topic will be trauma imaging in penetrating thoracic trauma, the role of CT. This is my disclosure slide. So what we're going to be talking about today is we're going to review the pathophysiology and mechanisms of penetrating injuries to the thorax, understand the utility of CT and the growing role of CT in the acute setting for thoracic injuries, particularly in the hemodynamically stable patients. We'll look at injuries to the heart, lungs and airways, the vasculature, and also the esophagus, diaphragm, and trachea as well. So we know that most of as I mentioned, the earlier talk, trauma is still the leading cause of death under the age of 45. We know that most are due to blunt trauma. However, penetrating trauma, although it's less common, it is extremely lethal with a 20 to 40% operative mortality rate. In the U.S., gunshot wounds are the second leading cause of death after motor vehicle collisions. In this example, initially I was asked by the trauma surgeon what to do in this particular patient. You can see there's numerous shotgun blast, numerous fragments, bullet fragments, and throughout the thorax. The surgeon didn't know what to do. He had no idea what to do. There were so many of these fragments, didn't know what was going on with the patient, so we just did a CT. And the VRT, let me see if I can go back here for a second. Yeah, let me go forward again. And basically when we did this CT examination, it was a nice demonstration of the VRT, most of these fragments, believe it or not, did not injure any single major organ in the thorax or any major vessel injury at all. The patient survived. He was discharged. So CT is playing a more and more increasing role in the management of these types of patients. So mechanism of injuries, most penetrating trauma in the U.S., of course, caused by stab wounds and gunshot wounds, can be thoracic or transmediastinal or thoraco-abdominal. Stab wounds are associated with lower velocities and more linear trajectories, and we'll see some examples. Gunshot wounds, on the other hand, are associated with varied trajectories as bullets are deflected by bone. Also depends on the type of bullet. Also depends on the type of tissue that the bullet traverses, of course. The more dense the tissue, the more catastrophic the injury. The more elastic the tissue, the less catastrophic the injury. And also the higher velocity versus a lower velocity also imparts different types of pathologies on the organs that we visualize. So if we look at this schematic depiction, usually you have a direct tissue laceration at the initial entry site of the bullet along the trajectory known as a permanent cavity, and this can range from 0.5 to 2 centimeters in length. And then the preceding shockwave injury that precedes the bullet also results in a pressure gradient perpendicular to the original tract of the bullet that can cause injuries ranging anywhere between 2 to 30 centimeters that's been reported in the literature. So we should be aware of the initial insult and also the permanent and the secondary cavities from the shockwave injury. Now, definitions, when should CT be prompted in the evaluation for life-threatening injuries to the mediastinum? Usually if you have entry and exit sites on opposite sides of the hemithorax, missile lodged in the opposite hemithorax from the initial entry point, and also a central penetrating injury that demands urgent CT. Now, CT is the modality of choice, and this has been accepted by surgeons and published in the Journal of Trauma and Acute Care Surgery in a prospective multicenter study of 453 patients. The hard signs, when you had active bleeding, instability, expandile pulsatile hematomas, bruits, thrills, hemoptysis, hematemesis, and air bubbling, those patients went for surgical exploration. Now, soft signs, venous oozing, non-expanding, non-pulsatile hematomas, monohemoptysis, dysphonia, dysphagia, subcutaneous emphysema, those underwent MDCTA. And what they found was sensitivity of 100% and a specificity of close to 98% for these types of injuries to the mediastinum. Very high sensitivity for aerodigestive injuries, although a lower specificity. So, in a state-of-the-art article published by Dr. Monero in Radiology in 2015, they what they do suggest, and some centers do, is a triple contrast examination for hemodynamically stable patients, usually giving oral, rectal, and intravenous contrast with arterial, venous, and delayed imaging, so triphasic examinations. And they found that it can be very useful for those types of injuries. Sometimes it can be very difficult for these penetrating injuries that they might, even though they might be entering into the thorax, they might disrupt some of the thoraco-abdominal organs, such as the bowel, the diaphragm, and the rectal and oral contrast can be very helpful for those types of injuries, particularly the abdominal visceral organ injuries, the bowel injuries, and also the rectum and the bladder injuries in the pelvis. But for this talk, we're concentrating on the thorax, and basically, if you have tangential or superficial wounds for pleural or peritoneal penetration, CT is demanded. For thoracoabdominal or anteroabdominal wounds, to rule out damage to the viscera or the major vasculature. Precordial, parasternal, periclavicular, and transmediastinal wounds. Definitely you have to rule out cardiac injuries that we'll talk about, great vessel injuries and aerodigestive injuries being critically important. Wounds that are not amenable to local exploration, gunshot primarily, bariatric patients, long oblique wounds also needs a CT examination, and maybe patients that are not responding to appropriate commands, that are intoxicated, neurological injuries, those where the physical exam is not reliable, those patients also require CT examination. So let's talk about the mediastinum and cardiac injuries. Now, one thing I would say that came to my attention is the cardiac box that I was taught by our trauma colleagues. The trauma box basically is from the top of the clavicles, anything medial to the nipples, and anything superior to the costal margin defines the cardiac box. If you see any or suspect any injury in that particular anatomic region, it's been shown that there's a very high incidence of significant cardiac injuries in that particular, known as the cardiac box. Now, however, it's also important to know with gunshot injuries that there was 21% of gunshot injuries also demonstrated cardiac injuries outside of this cardiac box. But be very careful and be very concerned if you see an injury or a subtle, even an entry point, I'll show some examples, that you might be dealing with a significant injury to the cardiac chambers. So penetrating hard wounds often result in hemodynamic instability, requiring immediate surgical intervention. Some of the CD findings that I'll go over with penetrating trauma, if you see pneumopericardium, hemopericardium, definitely they need surgical exploration, and I'll show some examples. This is a case from our institution where you could see a pneumopericardium. The red arrow is pointing to that. It's a very small injury, small hemopericardium. There's an effluent level in there, a pneumopericardium. This patient had a right atrial injury. We could not see that type of injury on our examination. Also, what I would say at our institution, if we do see an entry point in that cardiac box, we'll do a separate, dedicated cardiac CT with full functional analysis, and I'll show you the clinical utility of that. Another danger sign in this particular example, we can see a large hemopericardium. There's atrial inversion, bowing of the intraventricular septum towards the left ventricle. Those are indirect signs you're dealing with cardiac tamponade. That is also worrisome. This patient also had a right atrial injury. This particular patient, a penetrating injury, self-inflicted. We can see active contractilization into the pericardial sac. This patient was transferred to the OR immediately. This patient survived. This particular patient was an interesting patient. The one of my colleagues, Dr. Patrick McLaughlin, dealt with. You can see a massive hemothorax on the left. There's a gunshot wound, displacement of the cardiac chambers towards the right of the mediastinum. We did a CT because it was a functional analysis. It was very important because a decision needed to be made as to whether this patient was going to be transported upstairs to be put on a bypass machine. We can see the blue arrow points to the left ventricle anteriorly and laterally. There's a bullet fragment that's sitting right along the left ventricle. Is it within the myocardium, which was very important to the surgeon? If it is within the myocardium, they would put the patient on a bypass machine. We can see there's an area of low attenuation in the left ventricle indicating a contusion. So we did some wall motion analysis, and on the wall motion analysis on the following slide, you'll see there's decreased contractility of the heart, which is very important. You'll see the bullet fragment is lying on the surface of the left ventricle. So that was important findings for the surgeon to manage this patient conservatively with inotropic drugs, not to put them on a bypass machine. If they put them on a bypass machine, you'll see how significantly decreased the contractility of the heart is. The patient would have passed away. So if we look at the wall motion analysis on the next slide here, we can see this marked decreased contractility of the left ventricle on the short axis view and on the two-chamber view as well. I'll show you the marked decreased contractility. You can see the ventricle is just not contracting. This ejection fraction is close to like 15%, 15. So marked decreased contractility, like significant value added from a dedicated cardiac CT examination. Tracheobronchial injuries, one thing I would say from a penetrating injury, usually it affects the anterior extrathoracic trachea in the lower neck, compared to in blunt trauma, which is the most common site of injury in blunt trauma, is the bronchi or the posterior membranous portion of the trachea, which is located within 2 centimeters of the carina. So different locations for penetrating and blunt trauma. Now, delayed management can lead to stenosis, tracheoesophageal fistulas, recurrent infections and bronchiectasis, and permanent lung damage from chronic airway obstruction. One thing I would say, one important sign, the persistence of subcutaneous emphysema, pneumothorax, atelectasis on follow-up chest imaging should raise the possibility of a missed tracheobronchial injury. In this particular example, anteriorly we can see subcutaneous emphysema, a big hematoma, and also along the anterior aspect of the trachea, there's a low attenuating defect in keeping with the left paramedian anterior tracheal laceration from a stab wound to the neck. Thoracic vascular injuries, one thing I would say, venous injuries are more common in penetrating trauma than in blunt trauma. Some of the findings are pseudoaneurysms being the most common finding, vascular occlusions or intimal flaps, active contrast extravasation, and if you see earless venous filling, think of an AV fistula. In this particular example, there's occlusion of the left subclavian artery immediately distal to the takeoff of the left vertebral artery. For pulmonary injuries, we can look at hemothoraces, pulmonary contusions, lacerations, venous and arterial injuries as well. In this particular example, again, a very subtle stab wound in this cinematic rendering image. It's in the cardiac box. So, we really did a dedicated examination to the thorax. And we'll see right here, we can see the linear trajectory of a stab wound that we talked about earlier on, pulmonary hemorrhage, and it goes through the left inferior pulmonary vein with a low filling defect in the pulmonary vein. It's very subtle, but indicating traumatic injury to the left inferior pulmonary vein in addition to the pulmonary hemorrhage. Pulmonary arterial lacerations, these are very dangerous injuries, massive hemothoraces, pseudoaneurysms, active bleeding, can cause a pericardial tamponade, because remembering that the pericardium does reflect over the pulmonary trunk, and also tension pneumothoraces. Most common site is the hilum. We can see in this particular example, in the left lower lobe, there's numerous pseudoaneurysms, active bleeding from a pulmonary artery injury, and also a massive left hemothorax. Esophageal injuries, high rates of mortality. Most of these are associated with respiratory tract injuries, CNS injuries, and vascular injuries. Firearms are the majority of the cases for these types of injuries. And the cervical portion of the esophagus is the most commonly anatomical injured portion of the esophagus. Penetrating esophageal injuries, findings, if we see air bubbles, bullet fragments, or bone fragments adjacent to the esophagus, be very concerned for an esophageal perforation, thickening or discontinuation of the esophageal wall, and extravasation of oral contrast material. This particular example, we can see there's a cleft along the posterior aspect of the esophagus in keeping with a small laceration of the esophagus. So my last 2 slides, diaphragmatic injury, signs in blunt versus penetrating trauma. One thing I would say that in penetrating trauma, the discontinuous diaphragm sign, thickening of the diaphragm, and if you see an injury on either side of the diaphragm, it's a diaphragmatic injury until proven otherwise. But those are the 3 most common signs you'll see in penetrating over blunt injury to the diaphragm. This particular example, another cinematic rendered image that shows a flank wound, a stab wound to the left flank along the intervertebral margin. We can see there's discontinuity of the left hemidiaphragm pointed out by the red arrow. It's very thickened. We can also see a pseudoaneurysm. That area of blushing of contrast follows the same attenuation as the descending thoracic aorta. So that's a pseudoaneurysm in the spleen and a perisplenic hematoma. We can see on the coronal images the yellow arrow points to a thickened diaphragm, and again, discontinuity of the left hemidiaphragm in keeping with direct signs attributed to a penetrating injury. So in conclusion, mechanism of injury and anatomical landmarks are key when evaluating penetrating thoracic trauma. CT is the modality of choice. If you're suspecting a cardiac injury, do a dedicated cardiac CT examination with functional analysis. It'll be very useful. It can be life-changing for these patients. And rapid triage diagnosis is critical in these particular types of injuries. Thank you for your attention.